Vanessa Johnson, a 64-year-old African-American female, chief complaint of feeling tired and annoyed all the time. History of present illness, onset gradual 4 months ago. Location, overall general body fatigue. Duration is every day but worse in the evenings, characterized as constant tiredness with reduction of physical performance and endurance. She is unsure of aggravating factors. It is reducible by drinking water and resting. She denies any treatments to improve or that her prescribed medications help. She rates the severity of 6 out of 10. Her daily PO medications are metformin 1,000 milligrams, glyburide 20 milligrams, hydrochlorothiazide 25 milligrams, atenolol 25 milligrams. These are all by mouth, and she is only taking the atenolol, has stopped the other medications 6 months ago due to the side effects. No known allergies. Past medical history is hypertension for 10 years and diabetes type 2 for 7 years. Unremarkable surgical history. Mother has type 2 diabetes. Father and sister both passed away from MIs at the age of 58 and 67. No drinking, smoking, or drugs. Widow, 1 daughter, currently abstinent, living alone, suffering from grief for the loss of her sister. Unintentional weight loss of 5 pounds. Patient specifically denying recent infection, open wounds, or foot ulcers. She complains of blurred visions bilaterally. Last exam was 2 years ago. Complains of increased thirst. Patient denies chest pain, palpitations, P&D, orthopenia, or edema. Patient denies cough, wheezing, or dyspnea. GI unremarkable, but did complain of excessive gas, upset stomach, and diarrhea while taking metformin and glyburide. Patient confirms increased urinary frequency, denies burning, change in color or odor of urine, blood in the urine, vaginal, perineal itching, bleeding, foul odor, adnexal pain or tenderness. Patient states her last PAP was 9 years ago and was normal. Complains of tingling in her feet bilaterally. She expresses decreased interest in things that used to bring her joy due to fatigue and struggling with the loss of her sister. Vital signs are stable with the exception of BP 160 over 90. Her BMI is 29.8, so general appearance, adult female presenting with no acute distress, appearing overweight and fatigue. Diabetic retinopathy noted bilaterally upon ophthalmic scope inspection. No cervical lymphadenopathy. Thyromegaly or nodules palpable. S1 and S2 with regular rate and rhythm. No extra sounds, clicks, rubs, murmurs heard. Cap refill 2 seconds. Pulses +3 throughout. No edema, JVT, or carotid roots auscultated. Symmetric chest rise and fall equal and unlabored. Respirations are regular, lungs clear, auscultation bilaterally with resonant percussion within normal limits. All other systems are unremarkable upon assessment. Differential diagnosis includes unstable diabetes type 2. Her A1C is 8.5. Elevated BMI with their BMI being 29.8. And we need to do weight management to avoid exacerbation of comorbidities. Essential hypertension, the patient's specific family history, and diagnosis of hypertension for 10 years, medication non-compliance, and a current BP of 160 over 90. So we're going to run some tests, a CMP to rule out RAS, impaired RAS and parathyroid function, a CBC ruling out impaired renal function related to erythropoietin production, GFR ruling out DKD, lipid panel to rule out increased cardiovascular disease risk, A1C to identify our diabetes, our glucose control and adjust treatment, TSH ruling out thyroid dysfunction, UA ruling out the presence of UTI, leukocytes or protein or blood in the urine, microalbumin ruling out early signs of kidney disease, vitamin D to see if that is contributing to chronic fatigue, and ECG ruling out left atrial enlargement, MI, LVH, PVC, or AFib. A PAP and cervical screen is indicated at this time. Monofilament test is also a PHQ-2 two-question screening to assess depression. So our final diagnosis is essential hypertension, a multifactorial disease process without specific etiology consisting of contributing components such as aging, sympathetic nervous system overactivity, basal tone, altered sodium excretion, insulin resistance, obesity, stress, and increased RAS cascade, raising overall blood volume. It carries the highest morbidity and mortality due to her family history and multiple MI deaths of first-degree relatives, in addition to contributing factors such as her lifestyle, elevated BMI, African American race, and systolic blood pressure of 160. Our plan is to start amlodipine, 5 milligrams PO every day, Tresiba 10 units, SQ every day, and then a 1-a-day multivitamin for women over 50. Non-pharmacological recommendations include glucose monitoring via finger stick home blood pressure monitoring, talk therapy, relaxation, meditation, diet, regular physical activity. Culture considerations for Vanessa is to discontinue the beta blocker and initiate the calcium channel blocker, as this is proven to be more effective with African American patients. We're also going to send her out for a mammogram and a colonoscopy. We're going to educate her on healthy diet and exercise, finger stick counseling with blood sugar goals to be 80 to 130 fasting and less than 180 postprandial. Blood pressure monitoring with our goal of systolic being between 110 and 130, diastolic 80. We're going to let her know the signs and symptoms that women experience specifically to MI and when to seek emergency care, and go over all her medications using visual aids and teach back. We're going to refer to LMFT, ophthalmologist, and dietitian. We're going to follow up in 3 months to evaluate that medication regimen and that new A1C.